Hey again, guys. So I wanted to record this maybe mini lecture after reading some of your first forum posts about the things that you feel most uncomfortable with in acute care setting. So I know during our first class, I sort of flew through just a few lines and tubes, honestly, sort of under the assumption that you guys already had that and it was really just review material. And maybe it is, but you haven't thought about it or talked about it in a while or been able to apply it. So this is taking a deep dive into this. If this is an area that you don't feel uncomfortable with, then feel free to put me on 2 times speed, like I do my podcasts, or just listen to me while you're going for a run or doing something else, and then just stop if something piques your interest that you're not super familiar with. So we will go through this fairly in depth here. Here we go. So I'm going to start a super basic level, just talking about non-invasive monitoring devices. So devices that are providing you information about the patient that you can see on the monitor. Okay, so a blood pressure cuff. I told you I'm going basic, but I think that this will be good for review for you guys, especially in preparation for the board exam coming up. So remember, a blood pressure cuff is also known as a sphygmomanometer, probably my favorite word. So the purpose is to indirectly measure arterial blood pressure, and you'll often see this abbreviated NBP or non-invasive blood pressure. So on the monitor, I mentioned that different vital signs always have different colors. So the blood pressure is like a fuchsia type color. So normal, we talked about in class, is less than 120 for systolic, and diastolic should be less than 80. So both of those things have to be true in order for blood pressure to be normal. Implications for us, the biggest common error that we see in blood pressure measurement is that we're not using the right cuff size. So do you remember what the correct cuff size is? So remember the bladder, the plastic part inside the cuff, not the cuff itself, but the part that you can feel that inflates, should go about 80% around the patient's arm. And if you turn it widthwise, the width of the cuff should go about 40% around the patient's arm. So that's kind of a quick check. You can take an actual measurement, but that's usually the easiest way. And what you'll find sometimes in acute care, everybody already has a blood pressure cuff on when you walk into the room if they're in progressive care or higher. However, it's often not the right size. So if your cuff is too big, your pressure is going to look falsely low. And if your cuff is too small, your pressure is going to look falsely high. So just check the cuff size, easiest thing to fix. I've listed here some reasons why you would not check a blood pressure on an extremity. So art line is one, lymphedema, any sort of AV fistula or graft, which we'll talk about, a PICC line, blood clot, or if somebody's had a mastectomy, or even just lymph node removal on that side. So you'll often see this pink armband on a patient who has one of those issues on that side. Really, you'll just see that for a mastectomy or maybe a history of lymphedema. But when it comes to knowing not to check the blood pressure on an arm with a certain line in it, they won't have that that bracelet on. So that's really kind of up to you to remember. When you're checking it, make sure you're keeping the extremity still, ideally at heart level, keep the patient quiet. And the other thing, probably my number one piece of advice in acute care, is keep a cuff readily available. So like I said, a lot of patients will have a cuff on when you go into the room. Leave it on, take the monitor with you. There will be a portable monitor. The worst thing you could do is get out into the hallway and all of a sudden somebody's dizzy and they're looking diaphoretic and you don't have a way to check their blood pressure. So keep a cuff readily available. And if they don't have one on, then start looking around and seeing where you can identify one that you could use if you needed to. And these are sort of the various ways that you might see a blood pressure monitor. Okay, so telemetry or ECG monitoring. I know that Jim probably talked to you guys in depth about this. So this just allows for continuous monitoring of the heart rate and rhythm. Those electrodes also provide the reading that you'll see on the monitor for respiratory rate. So heart rate is usually green, respiratory rate is typically white. We talked about a normal heart rate and its normal sinus rhythm. Typically in the hospital, like when this is being monitored continuously, you're going to see either a 3-lead EKG or a 5-lead EKG. And sorry, I always use EKG and ECG interchangeably. I just can't decide which one I like better. So this is the layout you'll see when it's 3 or 5. Remember to get like a full-blown EKG in order to tell if somebody is, for instance, having a STEMI, one of you mentioned during class, you would need a full 12-lead EKG. So those are still done intermittently if somebody's having cardiac issues, but these are the type that you'll see for continuous monitoring to display on your screen. If you can't see them, if you can't see the patient's heart rate and rhythm, but they do have these electrodes on, then the data is being transmitted to a remote monitoring site. I'll show you what that looks like. So it could be transmitted to the monitor, or it could be just going to a box and that information is being transmitted elsewhere. So PT implications, if somebody's on telemetry, where it's being transmitted via that box, make sure that you notify the nurse prior to treatment, because chances are good that their at least heart rate is going to change while you're in there. So the nurse might get a call from the monitoring center saying, hey, why is your patient's heart rate 20 beats per minute higher now? So just make sure that they know that you're in there. Also, of course, you're assessing the baseline heart rate and rhythm in response with PT. These electrodes will often become dislodged. No reason to panic, just reconnect it. So they are little stickers. So sometimes just the sticker itself will peel off, just stick it back on. Or sometimes the actual electrode will become disconnected, in which case you just snap it back on. So this sort of phrase will help you remember where they go. If you look at the bottom right picture, this corresponds with that. So white goes on the right. There's different color electrodes. So the white one goes on the right. Snow is over grass. So that means the green one is below the white one. And then smoke over fire. So the left side is black over red. And then you've got the brown one just goes in the middle. Don't place an electrode directly over a pacemaker or defibrillator. Typically, you're not the one who has to make that decision, but in case it comes off and you see a patient has a pacemaker, don't put the electrode right on top of it. And realize that movement and manual techniques can cause artifact. So the monitor might beep at you that you're having some sort of life-threatening arrhythmia, but it might just be artifact. So it's important to be able to differentiate between those. And sometimes it's actually pretty difficult to do, and you might have to call somebody else to come in and help you figure that out. So this is what that telemetry monitoring room looks like, that picture on the left of that guy on the phone. So the data from multiple patients is being transmitted to his TV monitors. And he can look at that and he can make a phone call to the patient's nurse saying, hey, your patient just went into AFib, or their heart rate's 150 or whatever it is. And the nurse can go in and check on them. The box in the middle is what that telemetry box might look like. So you can't see the patient's heart rate using this. You'd have to manually check it. But that little box can just fit in the patient's pocket. And then what you're more used to seeing is that top right picture when somebody's being continuously monitored and you can see the results. And then the bottom right picture is just of the actual electrode that goes on the patient. Here's some examples of what can go wrong with EKG monitoring. So this top picture, the heart rate is 84. I don't know how it knows that because you can see it's a flat line. So in this situation, the patient is likely not in asystole, but the electrodes have become disconnected. And you can tell that the respiratory rate is a flat line too, because the same device monitors that. You can tell the patient isn't in asystole because they have a nice, beautiful waveform for their pulse oximeter where it's reading 98%. So in this case, you just need to find out what's disconnected and put it back on. Here's an example of what artifact can look like. So you've got nice normal sinus rhythm there, everything looks beautiful, and then you've got just this crazy, really narrow kind of QRS looking type waves. So that's probably, maybe you touch the patient's chest, or maybe they're just moving and you get this artifact. Could be a lot of different reasons. And this is where things get a little dicey. So looking at this EKG strip, it's hard to tell if this is artifact or if this is a life-threatening arrhythmia. So what I think, let me get my pen out. I think all of this is artifact, and I think this is probably ventricular tachycardia, although it could be artifact too. It's really hard to tell. So this would be one of those situations where you're probably monitoring the patient's symptoms more than anything. If I saw this on the monitor and I didn't know what it was, I would have somebody else come in and look at it and make sure it's not actually VTach, because obviously that would be pretty concerning. Whoops. And then this is VTach. So if this top one is artifact, Then look at the bottom one and look how similar they look. So just to illustrate that, it seems like, when you learned about EKGs and cardiopulm and you talked about VTAC, that usually looks like one of those obvious ones, like, duh, I'm never gonna miss that. But it really can look really similar to Artifact. Okay, so pulse oximeter, we talked about this one a bit. So just to go a little bit more into depth, the waveform. So this is the blue number. And you can see if you look closely, the boundaries of that wave, it sort of has a high and a low amplitude spot. Let me use my thing. So here's the top of this wave, here's the bottom of this wave. That wave is as high as it can go. So that's what you're looking for when you're evaluating the waveform. You want it to be high amplitude like this one, and you want it to be a nice, normal, regular, consistent waveform shape. So that's how you know you're getting a good reading. On the bottom picture, on this one that you might see, like you might use this in an outpatient setting, or this one, it's got these little bars on the side, and that's supposed to tell you how accurate the signal is when you don't have a waveform to look at. So this might be on a patient's finger, it could be on their ear, it could be on their toe. Just know where it is. Monitor any changes with exertion, and realize that there are a lot of reasons why somebody wouldn't have a good signal here. So peripheral vascular disease is common. Dysrhythmia like atrial fibrillation is a big one. If somebody has AFib, it's hard to get a good pulse ox reading. Nail polish, if somebody just has cold extremities, also is another big one, or if they're severely hypotensive and they're not really perfusing their extremities well. I think we talked about everything else here. Oops. Okay, and we talked about this, just being aware that small changes in SpO2 can result in big changes in PO2, which ultimately means big changes in tissue oxygenation. Okay, sequential compression devices. So you probably have seen these before, even in other settings. The purpose of these is to prevent VTE, which is venous thromboembolism. That just refers to DVT and PE. It's kind of that umbrella term. So this is used really commonly in the hospital because most patients in the hospital are not as ambulatory as usual. And it provides intermittent sequential compression to the patient, just like the name sounds. So for us, the biggest implications are just take them off when you are working with a patient and put them back on when you're done. Don't be lazy. One of my pet peeves is when people just disconnect them and you see the patient walking down the hall with their SCDs on. Just take them off. You don't need any additional fall hazards in addition to what we're already dealing with in the hospital. They're best applied if you squeeze out all the air before you put them back on. And make sure you don't put them on in some situations, like when somebody has an open wound on that limb or if they have a fracture in their leg. Okay, so invasive lines. Those are all the non-invasive ones. Excuse me. So one thing that I kind of preach regarding lines is when you go into a room, even if you think you already know what the patient has, be extra thorough. So start at one corner of the patient's bed, take their blanket off, completely uncover them, and identify everything that's going into them. If you have reason to suspect that there's something under their gown, like a surgical drain, lift their gown up. You can drape them to preserve modesty, but really make sure that you know where everything is, that you can identify what it is, and then if you can't, you are asking somebody for some additional assistance. So you just don't know what you don't know sometimes. So peripheral IV, we talked about this a little bit. So just know that this is primarily used to deliver things to a patient, whether that be fluids or medications, electrolytes, blood. It's not typically used to take things from a patient. So if a patient needs a blood sample, like to check their hemoglobin level or whatever it might be, they often have to still get a blood or a needle stick, and they can't often use the peripheral IV. So it's a short, flexible catheter that's inserted into a vein. It just goes in just a little bit under the skin. You'll usually see it covered with a transparent dressing like in the picture. One precaution to follow with all invasive lines is just don't pull them out. So that comes back to identifying everything, making sure you know where it is, and preparing the room before you have the patient move. Other things to be aware of are just watch the tubing. Oftentimes the tubing is really flexible, so it can kink really easily. So just be sure if the pump starts alarming at you, you'll see it say occluded. first thing you can do is just check the line itself and make sure it hasn't kinked anywhere. Also be on the lookout for any signs and symptoms that the IV has gone bad or infiltrated, or the patient has a phlebitis type situation going on, which is just inflammation of a vein. So some signs and symptoms of that could be pain, edema, redness, warmth, all those things. I mentioned you can unplug this from the wall power. So this is one of those things you don't have to ask, you can unplug it, and it has plenty of battery power. It will start beeping at you and give you quite a bit of notice if you do need to get back to a wall outlet and plug it in. And avoid blood pressure there if you can. This is not a contraindication to blood pressure. If you had a question about this on the test, it would be okay to check it there, but avoid it if you can, just because we don't want to increase the risk of an IV going bad and a patient having to get restuck. Okay, so we talked about the PCA. I think we talked about all of these things. Yeah. And the button will light up when it is, when medication is available. Hey, a PICC line. So peripherally inserted central catheter is what that stands for. And if you just read the name, it tells you exactly what it is. So it's inserted peripherally. The location in the pictures here are almost certainly where you will see a PICC line going in. And then it travels all the way up to essentially the heart. Your notes from your previous classes do say that it's in the heart. It's supposed to terminate really in the superior or inferior vena cava, depending on the insertion site, but often it will be in the right atrium, and that's usually not a huge deal. So knowing that it goes into the heart and it travels very close to the apex of the lung, for us, if you're coming to see a patient and they just got a PICC line placed, you need to wait until an x-ray has been done to make sure it's in the right place, because a complication of PICC line placement can be iatrogenic pneumothorax. Iatrogenic just means caused by a medical procedure such as a PICC line placement. So just wait for the chest x-ray results. A reason a patient would have these is typically to provide more long-term access than just a peripheral IV. So with a PICC line, patients can go home with them, they can go to other settings with them. And you might see anywhere from 1 to 3 actual lumens coming out. So if you look at the bottom picture, that person has a double lumen PICC. So it might just be used for different types of medications. You'll often see this in people who need to be on like long-term nutrition or long-term chemotherapy or something like that. Other things to be aware of: you cannot check a blood pressure on this side. So this is one of those things you need to memorize. They're not going to have a limb alert bracelet on. So be sure you're not checking on the side of a PICC line. And axillary crutches are in general not a good idea. So there's some conflict about this, but if you get asked a question like this on the board exam, the answer is definitely don't use axillary crutches. As you know, patients shouldn't be weight bearing through their axilla when they're using those, but they often do. And that can cause occlusion, that can cause thrombus formation. So just avoid those. People often also have some lifting restrictions. So if you have a patient who has a PICC line and they are, say, non-weight bearing, or for whatever reason, they're relying really heavily on their arms to walk, like with a walker, you might need to talk with the physician and make sure that that's okay. And I've had physicians say, yes, it's fine. And I have had situations where the physician has said, no, you need to come up with a different option, because I don't want them weight bearing more than 5 or 10 pounds through that arm. Okay, next is a vascular access port, or a portacath. So this has similar indications as a PICC line. You would have it for similar reasons, such as chemotherapy or long-term nutrition. But the difference is this line is completely indwelling. So you can see it under the skin there. It kind of looks similar to a pacemaker, but it usually is just round, whereas a pacemaker is often sort of more square or rectangle in shape. It's accessed via a needle. So the patient does have to have a needle put into their skin to access it. And then the device itself is already going into the patient's vein. And it terminates in the superior vena cava, similar to a PICC line. And PT implications are really just knowing what it is when you see it. So it's a portacath, and monitoring for any signs and symptoms of infection. Okay, so arterial line, we're going to talk about this a bit in complex med. I'll go into some more detail here though. So an art line is used to provide direct and continuous measurement of blood pressure. So with the non-invasive cuff, you hit the button, it checks the blood pressure, and the blood pressure pops up on the screen. With an arterial line, this is continuously monitoring it. So the blood pressure, it's going to be red, and you'll see it on the screen, and those numbers are going to be changing second to second. So this provides a real-time assessment of the patient's blood pressure. It's also often used to check ABGs on patients. So in somebody who's needing daily ABGs, they'll have an arterial line in likely so that they don't have to have an arterial stick every day because those can be pretty painful. So this catheter is rigid. You'll see in the SimLab, whereas with the peripheral IV, you can just easily compress that line and squeeze it together. With an arterial line, it's rigid and non-compressible. So that's one way to tell the difference between those. It's typically either radial or femoral, but it can be in any artery, so keep that in mind. And it connects to a transducer that somehow magically converts that pressure into an electrical signal that you'll see on the monitor. So it's going to have a waveform similar to what we saw with the SpO2. PT implications, don't pull it out. You know, you don't want to pull anything out, but if I had to pull something out, I would not go for the art line. So if you do though, don't panic, you know, apply pressure, firm pressure. This is going to be an arterial bleed. So you're going to get quick spurting blood and you need to stop it. So apply pressure and start yelling for somebody to help you. Monitor the pressure and the waveform. So, you know, you might see a wacky pressure showing up, but if the waveform isn't accurate, then realize it might not be accurate. If your waveform starts looking bad, readjust the limb. So if it's in the wrist, you know, have the patient, how do I do this? Have the patient assume a neutral wrist position and see if that fixes it. And if you can't, then call the nurse for assistance. Important to note with this, and you'll get practice with this in the SimLab, but there's a transducer attached to the arterial line, and this has to be in a certain position in order for the arterial blood pressure reading to be accurate. So I think I have a picture of that on the next page. And other implications are just no excessive sustained range of motion at the joint that it's going through. So remembering that this is rigid and it's in an artery, you don't want to, if it's radial, you really don't want to do any weight bearing through the wrist. Also, if it's femoral, you can get out of bed. You're not on bed rest or anything like that, but you have to use some extra caution, and you don't want to do any sustained hip flexion longer than 60 or greater than 60 degrees. So getting a patient out of bed, you know, you might have to have them kind of lean back when they're doing that. And then they can transfer, they can sit in a chair, but if I was going to leave a patient in a chair, I would probably make it be a reclining chair. Oh, and the other important thing is knowing why the patient has this line. So typically if somebody has an arterial line, there's a problem with their blood pressure, and we want those second to second vital sign information. So some of the medications that I talked about in your recorded complex med lectures, such as Levophed or norepinephrine, those will often be used to maintain a higher blood pressure. And usually when I see a patient who has an arterial line, they have it in because they're having issues with low blood pressure. So know why they have that line, what medications they're on, check the orders for the vital sign parameters. Again, I think I mentioned this in the complex med lecture, but often when somebody is having issues with low blood pressure, the physician will really just be concerned about the MAP. So trying to get their MAP at least 60 or 65 to make sure that the kidneys and the brain are getting adequate perfusion. So just know the parameters, check the chart for those orders. Oh, and no blood pressure on that side. So this is what that waveform looks like. It's the blue one. I mean, sorry, the red one. It's late. And this is kind of what that setup looks like, where it has the art line going into the radial artery here. It's connected to this rigid tubing that goes to a transducer. The transducer is also seen in this picture. That's what it looks like. And then that is connected to this pressure bag, which also has a bag of saline in it. So the pressure bag is compressing the saline. The saline is flowing back down this direction to prevent that blood from backflowing into the direction it's not supposed to go. So that's a little bit more complicated than you need to know. But what I want you to know is that this has a transducer and a waveform. So you can see this nice, pretty waveform down here, 123/58. That number in parentheses is the MAP. Same down here with the non-invasive blood pressure, the pink one. The MAP here is 91. You might notice that these two numbers are pretty far apart, right? We have a MAP of 76 and a MAP of 91. I would tend to believe the arterial pressure, although it might be worth rechecking the cuff blood pressure to see maybe there's an issue with the arterial line or something like that. And you will see, I know that might seem a little weird to you, but when a patient has an arterial line in, they will still have a blood pressure cuff on, and they'll still have blood pressure being checked at regular intervals. And that's partly to ensure that the art line is accurate and that it's matching up with the non-invasive pressure. And this is what I'm talking about with the transducer and calibration. So you've got the transducer here. So it could be laying in the patient's bed. It might be on one of these plastic things that is attached to an IV pole. You just have to trace the line back and find out where it is. This is another picture of what it looks like. But in order to get an accurate blood pressure reading, you have to hold the transducer where this X is. So at the phlebostatic axis around the fourth intercostal space. If the transducer is not at that location, the blood pressure that you see on the monitor is not accurate. So you might see some crazy numbers. You sit the patient up and their blood pressure says it's 200 over 100. Your first thing you need to do is just move that transducer up to that phlebostatic axis and then see what the monitor says at that point. Okay, so central venous catheter or central line. These are often placed as soon as a patient comes into the hospital if there's any thought that this patient is going to be fairly critically ill. So this is a way that to allow the physicians to give patients high doses of fluid or some really potent medications like those vasopressors that we're talking about in complex med. Those can't be given via a peripheral IV. So a central line just allows access to the vena cava quickly. It can also be used for blood draws. It can be used to give nutrition. You don't have to be in an ICU to have this line. It can also be used for transvenous pacing. So if somebody needs a temporary pacemaker, it can be done via central venous access. It terminates in the vena cava, either superior or inferior, depending on where it was inserted. And in addition to providing access for the patient, it also provides a CVP measurement. So I mentioned during class that this is not super important to us typically, like while you're working with a patient. I'm not usually looking for changes in their CVP necessarily, but it might give me an indication as I'm preparing to go treat the patient. Are they really volume overloaded? Or if they have a low CVP, are they really dehydrated? It really gives you a reflection of right atrial pressure. So normal 0 to 8. PT implications, again, knowing why the patient has it, realizing that many patients who have a central line are pretty critically ill. So just making sure that you've got an accurate picture of their medical status. And same thing as we saw with PICC line. This line can cause a pneumothorax, so make sure that if the patient just got it placed and you show up, that they've had a chest x-ray done first. And like an art line, this will also have a pressure bag and a transducer. So the transducer has to be in the right location to get an accurate measurement. Okay, so this is what that looks like. The number is circled there. Their CVP is 6, nice and normal. And it's blue. CVP is always blue. The top picture just shows kind of where it terminates, and then the bottom picture shows what it might look like on a patient. So this one has a femoral central line. And there's no, you know, with the central line, if it's in the groin, for instance, you don't have to take the same kind of precautions that you do with an arterial line. Because this line's going into a vein, it's more flexible. It allows you to be a little bit more liberal in your movements with the patient. I still wouldn't have them, you know, sit in a chair with their knee flexed or their hip flexed to 100 degrees for hours or anything like that, because you're likely going to cause some kinking and occlusion. But you don't have to be as cautious when you're doing something like transitioning out of bed. Okay, so an AV fistula or graft. This is used to provide access for long-term hemodialysis. A fistula, you may remember, I think we defined this back in INTEG, is where two organs join together. So in this case, that is an artery and a vein joining together. And that is in that picture. Let me get my drilling tool back out. So this is an example of a fistula where an artery and a vein are being surgically connected. A graft is this picture here, where it's the same concept, but they have to use an artificial device or a graft to connect those two things because the patient's vessels aren't quite as viable. So these two things have the same implications as far as we're concerned. It's almost always in the forearm. I have seen them in the groin and some other weird places, but typically you'll see it in the patient's forearm, and it looks like this sort of ropey appearance. So it's really important for us to know what this is and that the patient has one, because we cannot take blood pressure on this limb. You could ruin the fistula or the graft, and as you can see, it takes months for that to heal. And these patients, they have end-stage renal disease. They probably have diabetes. They've got all kinds of other problems, and this might have been their only feasible graft site. So definitely no blood pressure there. If you see a patient and they don't have one of those pink wristbands on, ask the nurse for one. Other things, avoid weight bearing like immediately after the procedure. So if they just got a fistula put in, avoid weight bearing for at least a day or two, and probably check with a physician before you resume weight bearing through that arm. And then hemodialysis. So as we're talking about fistulas and grafts, just thought I'd throw in some information about hemodialysis. So this is used when kidneys aren't functioning, and it can be used to control fluid volume, to change electrolyte balance, to change the balance of acids and bases in the body, and just to filter out waste that the patient's kidneys are not doing. So intermittent hemodialysis is what most patients are on. You'll see that abbreviated IHD. So that's typically 3 to 4 times a week for 3 to 4 hours at a time, although that's hugely variable in acute care. So at home, that might be somebody's normal schedule. But if they come into the hospital and they're there with, say they've got all these metabolic derangements or they've got significant fluid overload, you might see these patients being dialyzed like every day for a while. And keeping in mind, even with the normal hemodialysis schedule, the goal is to get rid of 2 days worth of excess fluid and solutes in just a 3 to 4 hour time period. So we're having huge fluid shifts during these times. And often if you've worked with these patients, you might have found issues such as orthostasis or just general fatigue after treatment is not unusual. Something else that we'll see in acute care is that a lot of times patients can't tolerate those huge volume shifts because they're too critically ill. So because of this, they might be on continuous dialysis. You'll see that abbreviated CVVH or CRRT. So that just allows for more gradual filtration that occurs over the course of 24 hours rather than 3 to 4. So there are some other implications for us if we have a patient who's on CVVH. We just have to take extra caution with the catheter itself. It might be in the jugular vein, it might be in the femoral vein, could be a multitude of locations, but those catheters tend to be a little bit finicky. So regardless if it's continuous or intermittent dialysis, sometimes you just have to kind of schedule around that treatment plan, realize that a patient might be fatigued, and definitely monitor for hypotension, especially with changes in position. Okay, a tracheostomy. You've probably seen these before. So this is a way to provide long-term ventilatory support to a patient. It does this by bypassing all of that dead space that we have in the upper airway where no gas exchange is occurring. So it's just an opening in the trachea itself. It can also help with a secretion management. A lot of times patients can get secretions up like to the level of a tracheostomy, but not all the way up to their mouth. So this allows for better management of those. Most tracheostomy tubes come with a cuff. Let me get my pointer out. So most of them come with a cuff. This is what the cuff is. And that can be inflated or deflated. So you'll see this little piece hanging outside of the patient's body. Here's another picture of it here. And that, if you look at that little piece that's external to the patient, it tells you if the cuff is inflated or deflated. So in this case, you can see this looks like it's got some air in it, and the cuff looks like it's inflated. In this case, this little blue thing is kind of deflated. So this tells me that the patient's tracheostomy cuff would be deflated there as well. So the main reason that's important to us is you might have heard of a Passymere valve. I'm assuming you talked about this in cardiopulmonary. This is this purple valve in the picture. And that can be placed on a patient's tracheostomy to allow them to vocalize. However, it's a one-way valve, so it does not allow air to flow out of it, only into it. So if you were to walk into a patient's room and you want to hear them talk, you see the passing mirror valve sitting beside them, so you decide to pick that up and pop it on their tracheostomy. If you didn't check the cuff first to see if that's deflated, they might not be able to exhale. So if the cuff's inflated and they have the passing mirror valve blocking the front of their tracheostomy here, then they can inhale air, but they can't exhale it. So you're going to really quickly run into some serious breathing complications. So just important to note that the cuff must be deflated. I don't expect you guys to know how to do that or feel comfortable doing that, but you need to know that you shouldn't just go in and pop a passing mirror valve on without talking to somebody. Other things to be aware of are that the passing mirror valve itself, it does provide some additional airway resistance. So it might decrease a patient's activity tolerance, and a progression of treatment for you might be adding a passing mirror valve on during activity. And just be cautious if you're seeing somebody and they just got a new trach. Bleeding is a common complication, so you just want to be extra cautious that there is no movement or tension on anything that is coming from that tube. And then an endotracheal tube. So you have probably seen pictures of this at least. We might have one of these in the sim lab. We don't have a ventilator in the sim lab though, so that's one thing we're missing that we won't be able to really see and visualize. But a purpose of an endotracheal tube is to secure the airway. It's temporary. This is often what's done in an emergent or urgent situation. And then if the patient cannot come off the ventilator, they might have to start talking about a tracheostomy so that they can do more functional things like talk, eat, those types of things down the road. It has a cuff as well. You don't have to be as concerned about this one because you wouldn't be putting a passing mirror valve on a patient. PT implications are to be really cautious. So an endotracheal tube is not a contraindication to mobility, although you might hear that depending on where you are. It is not, I assure you, but we need to be really cautious with it. You don't want to pull this out. This is securing a patient's airway. So use caution. If they're probably going to be on a ventilator, almost everybody with an endotracheal tube is. And they've got kind of some heavy tubing attached to them. So just be extra cautious that there is no tension on that tubing. I don't even like to have it just hang down because it looks heavy. So I hold it up, I have a tech with me. You need additional hands really. And the other important thing is to note the depth of insertion of this tube before and after mobilization. So there's little numbers on the side. It's kind of hard to see here, but those little numbers on the side of that endotracheal tube. And you can see those numbers if you look at the patient's teeth or lips. So you might see it and it says, say 27 centimeters. I don't know, I just made that up, but you would want to check that before you get a patient up. And then again, when you're done, just to be sure that that tube did not get advanced or pulled out at all. And this is what the ventilator tubing itself looks like. So I just put that in there just to illustrate it's kind of heavy. So make sure there's no tension. Okay, a chest tube we talked about. Yeah, I think we covered that. I think we covered this. More often you'll see a surgical drain not attached to wall section, but again, if it is, make sure you ask. It's not one of those things you just want to unplug. Oh, whoops, I didn't mean to leave this in. Well, you guys already know my music taste, I guess, from my background. But if you want some Halloween themed music, then listen to these songs. Okay, we talked about a Dobhoff tube. I'll go into a little bit more depth here. So this is providing enteral feedings. Enteral just means it's feeding the gut. So whereas with TPN, which I think we'll talk about in complex med, that's being given via the intravenous, being given intravenously, I should say. A Dobhoff tube or an NG tube you might hear it referred to is feeding the gut, the normal GI system. So it's inserted through the nostril and it can terminate in either the stomach or the duodenum. For us, this tends to be pretty uncomfortable. The patients generally handle it pretty well, but you can see the tube, going down the patient's throat. If they open their mouth wide, you can see it back there. So that can be pretty irritating. The tube in general can be pretty easily dislodged. This is one that you want to be really cautious of because it pulls out easily. So generally patients will have tape securing that to their face. Like you can see this baby has some tape on its face. So check that that's secure before you move the patient. This says here, I took this out of a textbook, it says to check whether the patient can be disconnected from feedings. one of my many soapboxes is that I really don't like to disconnect things unless I absolutely have to, and especially something like this that's providing nutrition to the patient when so many patients are already malnourished. So I really would probably never ask for it to be disconnected, but as a new grad, feel free. There would not be anything wrong with that. I just want you to kind of keep that in your mind. And again, the patient might be on aspiration precautions. The tube can be bridled. So if a tube is bridled, it'll have a lot more support. So this is an example of a bridling. So the tube is passing all the way around his nasal septum. I have seen patients pull those out still when they're bridled, but it's pretty rare and it would be really difficult for a patient to do. A nasogastric tube we talked about. So one thing I wanted to point out here, this is called an NG tube. You'll also hear a feeding tube called an NG tube. In fact, I just said that. So just know if it's providing nutrition or taking it out, you might not know until you actually see it. This type of a tube, the one that's removing things, tends to be larger in diameter. They're both uncomfortable, but you'll be able to tell by what it's attached to if it's taking things out of the patient's stomach or giving things to the patient's stomach. I think that's it with that. Some more long-term nutritional support options would be like a PEG tube or a PEJ tube. So the name is just determined by if it's in the stomach or the jejunum. Provide long-term nourishment for people who cannot get adequate nutrition the normal way. PT implications, watching the gait belt placement. So don't put it below the tube. So if you can see, if you put it, down here under the tube, it could potentially pull up and cause significant skin issues or maybe even pull the tube out. So put the gait belt up here. And the patient still might be on aspiration precautions if they have this. That's what I talked about with the Dobhoff tube, where you can't lay them flat without pausing their feedings because it increases their risk of aspiration. Pee and poop. So we're going to talk about pee and poop next. These are actually some mascots in Vancouver that educate people on what you can and cannot flush down the toilet. So we talked about Foley. I think you guys are pretty familiar with this. Purpose, I guess we didn't mention that. So a lot of times a Foley will be used for a multitude of reasons. It could be used because the patient's incontinent and we're concerned about skin breakdown, so we're trying to keep them dry. It could be used because somebody is really dehydrated or they're really fluid overloaded, and we want to make sure that we have an accurate account of how much urine they're producing. So you'll see this often in renal failure, heart failure. Once the tube is inserted, so it's inserted into the urethra, and then it has a cuff that's inflated around it. So it's held in place. It shouldn't be an easy line to pull out. In addition to that, it has should have this kind of cath secure type device, which is tape with a little plastic piece that's applied to a patient's leg, and then the catheter tubing can kind of snap into place. So you've got multiple barriers to keep you from pulling this out. And this is generally what you'll see, like a Foley bag. But if a patient is using a catheter long-term, you might see this drainage collection bag that they can kind of tie on their leg. So I mentioned keeping it below the bladder, but also make sure you're not putting it on the floor or on something dirty. It can be a fall risk. I've seen patients fall over their catheter tubing. So when you're working with a patient, either secure it to their assistive device, like if they're using a walker, you can put it on there. Or you could maybe secure it to your clothing or the patient's clothing. You might have to get a bit creative if you're running out of hands. And a suprapubic catheter is just a more permanent catheter option. So often used if somebody's needing a long-term Foley, has a little bit lower risk of infection. It's placed directly through the abdominal wall, similar precautions to a PEG tube. Watch your gait belt placement, keep the collection bag still below the bladder. You might see a condom catheter, AKA Texas catheter, in males. So this is just literally just like a condom that is put on to help drain urine that way in a non-invasive manner, so it decreases the risk of infection. PT implication is this is never going to stay on. It comes off all the time. So my best advice to you is to look at it before you get the patient up, lift their gown up, see if it's even on in the first place, because a lot of times it's not. So if it's not on, then, you don't have to put it back on, just leave it off. But if it does come off during your treatment, let the nurse know. They'll have to get a new one and put it back on. And then some rectal type devices. So rectal tube or rectal trumpet, there's all kinds of rectal collection devices, or poop collection devices, I should say, not rectal collection. So this picture in the bottom right is not what a rectal trumpet looks like. It's more like this picture here, where it's inserted into the patient's rectum, and then it's secured because it's just big. So it's not, it doesn't have like a balloon that inflates typically or anything like that. But it's used to temporarily collect stool. And as you can probably imagine, this really is only effective if the patient is having liquid stool. So we talked about C. diff. You'll often see these devices in people with C. diff or people who have explosive diarrhea for some other reason. This, like a catheter, like a Foley catheter, this will be used to protect the skin and prevent infection. So you might see this in somebody who already has a wound on their butt to keep that wound from getting dirty. PT implications, this is very easily dislodged. So I consider it a success if I work with a patient and this doesn't come out. Yeah, so just use caution with this, but do the best you can. Try to avoid any shearing, don't slide the patient in bed. Sometimes this might be hooked up to wall suction also, which is kind of gross if it's just sucking it out and collecting in a canister by the patient's bed. Typically, when I've had patients with these, they are not mobile enough to leave the bedside anyway, but if they were, you'd have to check with the nurse regarding disconnecting that. Okay, and that's all I have. I didn't include any information about oxygen delivery here. We're not gonna, our simulated cases really don't have much in the way of oxygen delivery just because of some limitations of the sim lab itself. So I think that we will save that for one of our later classes. So I hope that this was helpful. Let me know if you have any questions. I'll see you guys next week. Bye.